Hello, everybody. Welcome to Grand Rounds. We are happy to have you and happy to have joining us Dr. Jenny Lin, who many of you know. She has been a part of the system-wide Department of Medicine for a long time. She's been a clinician educator at the residency and medical school levels, and now a clinician investigator with funding from the American Cancer Society and the National Cancer Institute, looking at comorbid illness, among other things, which you'll get to hear about today. She's also the mentoring director for the Department of Medicine and the fellowship director for the Division of General Internal Medicine Research Fellowship Program, and is associate director of the Medical School Research Office, where she's responsible for helping medical students find research mentors and projects. We've been trying to collaborate a lot with her to make sure that our mentorship programs here are as good as they need to be. And so I'm sure you'll be seeing lots more Dr. Lin in the future. Now we're happy to turn it over to her to talk about comorbid disease. Dr. Lin.
Great, thank you so much for that lovely introduction. I really want to thank Ryan and Matt for inviting me to speak with you all. I know that the Grand Rounds format tends to be a little bit more passive, and to appreciate that, people aren't on video, and and that's fine. I do want to make this as interactive as possible, and I do have a lot of slides to get through, so I may not get through them all, but if you have any questions, I may not be able to see the chat because I'll have my screen share on, but hopefully Ryan will be able to see the chat and help just chime in if there are any questions, comments, or concerns, or any issues. And again, really thank you all for having me. So let me just share my screen and start the talk. Hopefully you can all see my screen. Really, I am a primary care physician, and I, as many of you, especially if you're in primary care, deal with and take care of patients with multimorbidity. My research interests are really in sort of understanding how these comorbidities, really common ones like hypertension and diabetes, influence cancer survivorship. So that's what I'm going to talk a little bit about today. I have no conflicts of interest. The outline for the talk today is this. I'm going to start with a little bit of background. I'm going to sort of breeze through a number of these slides, because I think a number of these things are things that you already know. And then I'll talk a little bit about comorbidities in cancer, and then I know it looks like it's saying the same thing over and over again, but then I'm going to talk a little bit about cancer and comorbidities. And herein, I'm going to talk about first how comorbidities affect cancer, and then later how cancer affects comorbidities, which is my area of research. And then last, if we have time, I'll flip back to how comorbidities may influence cancer and cancer outcomes. So as a brief background, we're going to talk about cancer really quickly. As everyone knows, cancer is the second leading cause of death in the US. It still is, although given the inroads that have been made in the last 50 years with heart disease, it's really sort of coming in a very close second, but it's pretty much right up there as a major leading cause of death in the US. When you look at data from the CDC, this is relatively recent. This is the most recent I could find, which was published last year. Heart disease and cancer, again, right there, number one. Number two, in terms of age-adjusted death rates per 100,000. And you can see that there is actually over the 2 years from 2018 to 2019 a decline, which is really great, right? When you see the decline in cancer rates and in not cancer rates, in cancer deaths and heart disease deaths over the course of 2 years. When you look at cancer, the number one causes of cancer in males are prostate and breast in females. This is not looking at non-melanoma skin cancer, so that's the first for everything. But if we take those out, so prostate for men, breast for women, and then lung for both as number 2, and colorectal is number 3 in terms of incidence. When we look at deaths, again, still, and that hasn't changed very much. This is from earlier this year. This was compiled. And lung is number 1 for both, prostate number 2 for males, and number 2 for, and breast number 2 for females. Breast and prostate cancer, very, very common, right? 250,000 or 280,000 men and women respectively develop breast cancer each, or prostate cancer each year, right? So it's 250,000 new cases of prostate cancer in men, 280,000 new cases of breast cancer in women every year. But causes of death per year is very low comparatively, right? 34,000, 43,000 for breast. So, you know, a pretty good if you have to get cancer to get, because they tend to be caught early, they're relatively indolent, and so you can live with them for a long time. And the reason I'm making such a point about this is because that sort of goes into the next part of the talk a little bit later when I talk about cancer and comorbidities. So again, nothing that you guys don't already know, and then some risks for cancer, genetics, environment, and behaviors. Diabetes, if you look through, diabetes has really grown over time, right? So when you look at these maps of the US and you look and see how prevalent diabetes is, and this is just amongst people who know their diagnosis, not even amongst people who don't have it, you can see that that map just, you know, grows redder and redder. And currently, 34 million people in the US have diabetes, about 10% of the population. In adults, it's about 13%. And amongst adults older than 65, it's more than a quarter. All right, who have diabetes. Minority groups, Asians, Hispanics, non-Hispanic Blacks are all at higher risk for diabetes, and it is projected to increase to up to 48 million by the year 2050. Currently, in addition to the 34 million people who have diabetes and it's diagnosed, 88 million people, so about a third of the US population currently has pre-diabetes. So again, a major illness and highly prevalent. It's the 7th leading cause of death in the US, and the total direct and indirect estimated cost was 327 billion. This is just in the US a couple of years ago. So that's just sort of a quick overview of the background and probably things that most people already know, but just wanted to sort of remind everybody about it. So I'm going to move into talking a little bit about how comorbidities may affect cancer. And this is all sort of data that's also been known for a while, just to sort of get you guys thinking about it. So I'm going to use diabetes as the primary one because it's the one that we have the most data for. So diabetes and cancer risk. So we know from epidemiologic studies that diabetes increases your risk for developing cancer. Okay, not for all cancers. So interestingly, for prostate cancer, it's lower, but for many common cancers, breast, colorectal, hepatocellular, endometrial, the relative risk is anywhere from 1.2 to 2 times greater risk for developing these cancers if you have diabetes versus if you didn't. When you look at sort of these large meta-analyses, you can see that, you know, for women, the overall risk for developing cancer if you have diabetes is essentially 1.3, so 30% greater chance of developing cancer if you have diabetes than if you don't. And again, you can take a look at the forest plot and see the majority of it is sort of, you know, weighted by breast, because of course that's the most prevalent cancer in women. But you can see sort of the bars for some of these other cancers, you know, hepatocellular, like 2 to 3 times greater risk if you have diabetes than if you don't have diabetes for developing HCC. In men, what you'll see is that the number crosses 1, so it doesn't look statistically significant, and that's really primarily driven by prostate, because again, that's the most common cancer in men. And diabetes apparently seems to sort of be associated with a slightly decreased risk for developing prostate cancer, although it is associated with a much higher risk for developing a number of other cancers, including bladder, colorectal, and pancreatic. So diabetes increases your risk for developing cancer. And why might this be, right? So a couple of thoughts and reasons. One, there's insulin resistance and hyperinsulinemia that often occurs in patients with type 2 diabetes, and insulin can act directly to stimulate mitosis in tumor cells. It can also act indirectly to modulate circulating growth factors and binding proteins, and that increases cell proliferation. And lastly, insulin can activate growth factor receptors like the insulin-like growth factor, which can stimulate cell growth. Right, so that's a potential mechanism for its higher risk. The other thing is, in patients with diabetes, and again, this is primarily type 2 diabetes, there is often increased level of steroid or peptide hormones. And so these can then also either increase cell growth, so higher levels of leptin, increases endothelial cell growth, suppresses apoptosis, and then reduced levels of adiponectin, which inhibits inflammation and cell growth. Can then lead to more cell growth. So if you have diabetes, you have these reduced levels. Just ignore that phone. I can't turn it off. Lastly, there are increased levels of pro-inflammatory markers such as IL-6 and TNF-alpha in patients with diabetes. And so we think of diabetes as sometimes a little bit of an inflammatory state, especially with uncontrolled diabetes. And these inflammatory markers also can stimulate cell growth. And lastly, hyperglycemia itself may create a sort of oxidative process that can also seem to increase cell growth. So this is a really great review paper by Emily Gallagher and Derek Leroy in Endocrine, basically just showing a really nice set of figures about how obesity and diabetes may then lead to cancer. And again, sort of a number of things we touched upon, the inflammatory markers, IL-6, IL-1 beta, TNF-alpha, the hyperinsulinemia, which leads to hyperglycemia, and then the steroid and peptide hormones that we talked about. What about diabetes and cancer prognosis? So I hope I've made a pretty strong argument. Diabetes in and of itself can increase the risk for developing most cancers, not all, but many of them, and certainly many of the common ones. But what about diabetes and cancer prognosis? So not surprisingly, diabetes overall worsens survival, and this is overall survival. So cancer survivors, so you've got your cancer already. If they have diabetes, they have worse overall survival compared to those without diabetes. There are these large meta-analyses that show a hazard ratio of 1.4, 1.2, but again, 20 to 40% greater risk of dying if you have diabetes than if you don't have diabetes, if you have cancer. And this is with, a variety of different types of cancers. These are all the different studies that were studied, but 1.4, so that's a pretty high ratio. Now, again, this is overall survival. So you can make the argument, maybe they're dying because they have diabetes and they have, heart disease because they have diabetes, which I would argue is true to some extent. But diabetes itself also worsens cancer prognosis. So cancer-specific survival is actually worse in patients with diabetes. And so, if you have breast cancer and you have diabetes, you're more likely to die from breast cancer than if you have breast cancer and you don't have diabetes. And again, these hazard ratios are pretty significant, 1.3, 1.4, so 30 to 40% greater risk of dying from your cancer if you have cancer and diabetes than if you just have cancer alone. And interestingly here, you'll see for prostate, right? We talked about how prostate cancer risk is decreased. It appears in patients with diabetes. But if you happen to get prostate cancer and you have diabetes, you have like a 50% greater hazard of dying from prostate cancer than if you had prostate cancer and you didn't have diabetes. Diabetes itself also seems to worsen risks of recurrence, which makes sense. Studies show that it increases your rate of getting a recurrence of your cancer. And then hyperglycemia itself, in terms of a mechanism for why patients have worse cancer-specific survival, seems to be associated with more aggressive cancers of presentation, decreased response to chemotherapy and breast cancer, decreased responses to radiation therapy and prostate cancer, and higher risks of complication following radiation therapy. So these are all studies that are probably almost a decade old now. So this is not sort of super new knowledge, but I just wanted to sort of get people's minds sort of in the mode of thinking about how comorbidities, and in this particular case, I'm using cancer as the example, can influence both cancer incidence as well as cancer prognosis. Let me take a pause because I know I've been speaking pretty quickly. Make sure that there are no questions before I move on. Okay, fabulous. So, what I'm going to talk about next is really the work that I've been doing, and I'll probably take this a little bit slower. And so I'm really going to be talking about cancer and comorbidities. And what I'm most interested in is how does having cancer affect how a patient manages or thinks about their comorbidities. And again, that really stems from the fact that I'm a primary care physician. So I don't actually treat cancer. I treat patients with cancer as well as many other illnesses. And, my main interest is thinking about how having cancer then may or may not influence how you take care of your other illnesses, because those are the patients I end up seeing in my practice. So I'm going to talk a little bit for the background part is sort of having you think about something that I alluded to earlier, which is, there is a growing number of cancer survivors and they live with multiple comorbid illnesses, diabetes, hypertension, heart disease being the top. A quarter of cancer survivors actually currently die from illnesses other than their cancer. So cancer used to be in the 50s and 60s, like this death sentence, right? People wouldn't even want to say the word. Because we didn't have as many good treatment options. We weren't detecting them early, number of reasons. But nowadays, cancer survivors really live for a very long time. And many cancers more and more are being treated actually as more chronic illnesses and being able to be treated in the outpatient with oral medications, which is what we use, obviously, in primary care. We don't really give people IVs in primary care. It's sort of not the way primary care tends to work. And cancer is more and more sort of becoming more of a chronic illness, which is really interesting. And just to remind everybody that heart disease is still the primary cause of death among breast and prostate cancer survivors. Again, because these cancers tend to be diagnosed early and or are indolent. And these cancer survivors live for a very, very long time and consequently end up not dying from their cancer because it's either been cured or it's been put into remission for long enough that there isn't a recurrence, at least before they die of another illness like heart disease. So when you look at causes of death in cancer survivors, this is a little bit of a busy slide. And so, I just want to walk people through it. And it's not, perfect, but you can see the bottom is over time, 1975 to 2008. Can you guys see my pointer? Hopefully. Anyway, the green indicates deaths that are not due to cancer. The gray indicates deaths that are due to another cancer, not the primary cancer, and the black indicates death from the primary cancer. And so you can see, back in 1975, like if you got cancer, 75% of the people who got cancer died from their cancer, right? And 25% died from something else. And so, now this is only up through like 2010 or 2011. Maybe 2015, that the percent of people who actually die from their cancer has gone from 75 or 70-ish down to 50. So that's remarkable in terms of causes of death. And then consequently, the other cause of death is primarily made up of non-cancer causes. In panel B over here, what you can see is this is black. So this is representing this black part. So these are broken down by disease state, people who are dying from their primary cancer. And in the purple, which is the biggest one that you see, it is lung, right? Because many people who have lung cancer end up dying from their lung cancer because lung cancer is still pretty deadly and often, due to not being caught early enough, although that may change again with the lung cancer screening becoming more sort of utilized. And then what you can see in D here, which is what I think is interesting, is that the biggest bars are the light blue, which represents prostate, and the pink, which represents breast. And so this is the percentage of people amongst all the people who are dying of non-cancer causes who have prostate and who have breast, right? So breast and prostate cancer survivors live for a pretty long time, and they often end up dying of not their cancer, but of something else. Even when you look at lung cancer, and this is a study we did a couple of years ago in SEER Medicare, you can see that among cancer survivors who are sort of 7 to 12 years out from their diagnosis, that a good almost third of them, so this is the bar here of, other non-cancer causes, the primary one of which being, cardiovascular or COPD, and again, because these are lung cancer survivors. But if you're, 7 to 12 years out from your lung cancer diagnosis, you're as likely, almost, to die of something that's not lung cancer than it is lung cancer. And if you're older here, right, so these are the young people, if you're older here, you can see that the majority of people who die when they have lung cancer, they actually don't die from their lung cancer. They die of a non-lung cancer cause, right? They die of COPD or heart disease or something else, but they're not dying from their lung cancer. So that's sort of what this is showing, is that even amongst lung cancer survivors, depending on how far out you are and when you get diagnosed, and these are early stage lung cancer, so these are stage 1, obviously, a number of them are dying from not their lung cancer. So, why do we care, right? So some, cancer survivors report more comorbid illnesses in the general population, and that makes sense because some of the behaviors that increase your risk for, say, lung cancer also increase your risk, say, for heart disease. And so, cancer survivors do have more comorbidities in the general population. And then comorbidities really negatively impact cancer survivors' overall health and their quality of life. Cancer survivors with more comorbidities report worse physical functioning, lower social functioning in terms of higher levels of mental health and depression, and worse quality of life overall. So this was the basis of sort of my first project, sort of thinking about, okay, so we know comorbidities negatively affect cancer survivorship, right? Cancer risk, cancer survivor, both overall and cancer specific. But, how does cancer affect management of chronic illnesses? Can it make people not take care of their diabetes? And that's a problem because, like we just talked about, breast cancer, prostate cancer, those patients, those survivors end up primarily dying not of the cancer, but of something else, right? And heart disease is still the #1 cause of death in these populations. So if you get cancer and you're like, oh my goodness, I'm so worried about my cancer, right? So this worry about cancer progression. And you say, whatever, I'm just going to have my cake and eat it too, and I have diabetes because I have cancer and I just need to, I'm going to die anyway, so I might as well just enjoy my cake. That could be problematic, right? And we know that poor self-management behaviors, medication, diet adherence, right, lead to poor disease control. So the hypothesis was this: if cancer has a negative effect on self-management behaviors, cancer survivors' morbidity and mortality risk may increase due to poor control. And so our job was to try to understand this a little bit better. So the first project here was this impact of cancer on adherence in diabetes. And so the objective of this project was to evaluate the effect of a new diagnosis of an early stage breast, prostate, colorectal, or lung cancer on self-management behaviors in patients with diabetes. So what we did was we enrolled patients with diabetes who didn't have cancer, and we also enrolled patients with diabetes who were newly diagnosed with cancer. And we followed them over the course of about a year to assess how their A1C changed over that time, and specifically how their medication adherence as well as their beliefs about their illnesses may or may not have changed over time. The study was completed enrollment about, I want to say 3-4 years ago. And so overall, we enrolled about 170 patients, half of them approximately with cancer, half without. You can see that overall the age and gender and race, not race, ethnicity, age and gender were matched because we matched the controls on this. They actually, it's not in here because it's on a different table. We're also matched on A1C levels, so that they all started at about, well, the cancer patient, the control patient started about the same level. They were a little bit different in terms of education levels. Cancer patients in general had a slightly 65% versus 55%, slightly higher percentage had college education, and slightly and a much larger percentage, 53 versus 31%, were above the poverty level. And then these were the different cancer types. Again, mostly breast and prostate cancer survivors, and a very few colorectal and lung. Again, very early stage. And so we were looking at self-management behaviors and taking a look to see if there was any difference in these self-management behaviors for diabetes between cancer survivors and controls, right? Patients without cancer, and found that there was some difference, and that patients with cancer generally tested their blood sugars a little bit less often than patients without cancer. And so this first one is, number of days that they test. And then the second one is, number of days they tested as they were supposed to be recommended to do. So if you were only, testing once a day versus twice a day. But actually the number of days that they exercised, or that they reported exercising, or eating well, or sort of, checking their feet for sores and ulcers, were actually the same between the two groups. So really sort of the blood testing was different between the group. We also took a look to see, this is about diabetes medication adherence. So we gave them these pill bottles so that they could measure and we could monitor how often they were taking their medications. And we saw that cancer patients were somewhat less adherent than non-cancer patients to their diabetes medications. And this is 3 months after enrollment, but by about a year, it's about the same. So a slight difference at 3 months, but generally about the same. And adherence here is, just so you know, we in the literature tend to say patients are adherent if they're taking their medications 80% of the time as prescribed. So if you're taking, you're supposed to be taking your metformin twice a day, every day for a week, and you take it twice a day every day, but 2 or 3 days a week you take it once a day, that still would be considered adherent. But so if you're taking your medication at 80% or more of what you were prescribed to be taking it, that was considered adherent. And so 73% of cancer patients are adherent versus almost 80% of non-cancer patients are adherent 3 months after enrollment. But it's pretty much equalized to about the same, 75 and about 73. When you look at their behavior, so again, this is looking at like how often they're testing their sugar, how often they're doing exercise, how often they're eating high-fat food, and this is over time, because again, we had followed these patients over time. You can see that initially there seems to be a difference, and there definitely was a difference in terms of the number of days a week that they're checking their sugars between cancer patients and non-cancer patients. Non-cancer patients checking their finger sticks more often than cancer patients, but overall it sort of seems to even out. And then the number of days per week that they're checking their feet, again, seems to be a little bit different, but then evens out by a year. And you can think about reasons why this might be, because these are all patients, for the cancer patients, who are newly diagnosed. We enrolled patients within 3 months of a cancer diagnosis. So 3 months after enrollment, they're still probably in the middle of getting treatment and therapy, and so for their cancer, and so their diabetes may be really taking a back burner. And so I think we see a little bit of that, and then how over time it seems to equalize. When we're looking at cancer patients just themselves, one of the things that I was really interested in is looking at cancer-related stress, or cancer-related sort of this post-traumatic stress type symptoms. And so there is a measure called the IESR, that the R is the revised impact of events scale, taking a look to see how much their cancer diagnosis is causing them distress, right? And so causing them distress with regards to, they're trying to avoid their thoughts about cancer, for example. And so you can score them on this, and you can get a risk score. And those who are scoring at or above 26, the way the instrument is done, there's a suggestion of possible PTSD, but it's not a diagnosis of PTSD, but it's a suggestion that this event, and here we asked specifically about cancer, is causing a lot of distress, a lot of post-traumatic stress. And so you can see that 38% of the patients in our study, these are just the cancer patients, reported pretty significant cancer-related distress, right? Suggestive of this cancer-related PTSD symptoms. And one of the things that we can take a look at is looking to see whether or not these distress scores change over time. And this is between baseline when they were enrolled and 3 months later amongst the cancer patients, and they don't. They seem to drop a little bit, but again, not statistically significantly so. And so the cancer-related distress seems to at least persist for at least 3 months since enrollment. So probably overall, at least 6 months since diagnosis. And the interesting thing is that if you have more distress, if you have a lot of these avoidant thoughts, if you have a lot of these intrusive thoughts where cancer is, constantly invading in your thoughts, or you're doing things deliberately to try to not think about cancer, these patients in the dark blue are much less likely to report exercising than patients who don't have this cancer-related distress. So, we can see that some of these factors of cancer, and this is sort of where I'm really interested in, can affect self-management behaviors such as diet or exercise or medication adherence. And so, not so much so for medication adherence, and not so much so for diet, but for exercise, it seems that if you have higher levels of cancer-related distress in terms of avoidance thoughts or intrusive thoughts, you are less likely to exercise. So that was one small study that came out of that project. One of the other things that we looked at was illness beliefs and behavior. So like I said, one of the things I'm really interested in is how do people with cancer and another illness think about their illnesses relative to one another, right? So many of our patients are dealing with multimorbidity, and when you have one that's sort of more chronic and considered to be indolent, that is like diabetes, you've had it for a while, and you get a new potentially mortal illness like cancer, and that has so much more emotional valence attached to it often for people. How does that affect their behaviors, and how do people think about it? So here we looked at differences in beliefs about cancer versus diabetes amongst cancer survivors. So again, this is just in the group of cancer survivors, and we were really looking to see what their scores were. Higher scores, indicate a stronger belief. So again, people think about their cancer and their diabetes very differently. How much does the illness affect your life, right? It affects, cancer affects your life much more, or these patients' lives much more than diabetes did, right? An 8 versus a 4. And this is on a scale of 0 to 10, just to be clear. How long will your illness continue? I thought this was fascinating, right? Diabetes scores 10, right? 10 meaning like it's long-term, it's chronic. 0 meaning like it's an acute illness, it's done, right? And so the median score for cancer was 0. People really think of their cancer as not something that goes on, but that's something that's done, taken care of, and out of their lives. And it's really interesting. I think generally we need to think of it that way. More and more we're finding with different cancers that people are starting to be able to conceptualize it as a chronic illness and something that needs to be controlled, but not necessarily be gotten rid of. But interestingly, this is borne out here. How much control do you feel like you have over your illness? People feel a little bit more control over their diabetes than they do with their cancer. And again, it, I think, speaks to how cancer is still primarily being treated, which is in the doctor's office, getting the chemotherapy, or getting the radiation, or having the surgery, rather than sort of something that you're doing to manage your diet. Although we do know that diet and exercise really can also influence cancer and cancer prognosis, but that's a whole separate issue. And lastly, how much does your illness affect you emotionally, right? Diabetes, 2, doesn't really affect them emotionally. Sort of like, been there, done that. Cancer's an 8, so pretty high. So pretty significant differences in beliefs about cancer versus diabetes, and not surprising. When you think about how these beliefs may influence how people take care of their illness, this is sort of where my interest is in. So there have been, for a long time, some data looking at your beliefs about your illness and how that affects how you manage your illness. But generally, it's like your belief about your diabetes and how that then affects how you take care of your diabetes, which makes a lot of sense. Up until recently, there really wasn't anything looking at how your belief about one illness may then influence how you take care of another illness. And that's really what I'm interested in. And so we looked here at 2 factors. So back, you can see, people didn't feel like they had a lot of control about their cancer overall, and cancer impacting their lives a lot. So what we found was that in patients who felt that they had higher control, right, they scored higher on that control question over their cancer, actually seemed to also check their sugars more often. If your cancer impacts your life more, right? So cancer is really impacting, you're checking your sugars less than if cancer is impacting your life less. If cancer impacts your life less, and again, this, is borne out with the earlier study I talked about in terms of like the, cancer-related distress. So if you don't have as much distress, if it's impacting your life less, you are exercising on average 1.5 days, maybe at least one day more than people who report that cancer has a big impact on their life. So we can now start to see that beliefs about one illness may impact how people behave and take care of a different illness. And so that was pretty new. So in summary, right, cancer survivors who feel that they have more control over the cancer are more likely to check their finger sticks more often. Cancer survivors who report that cancer has less of an impact are more likely to exercise, as well as check their finger sticks more often. So that's a little bit of a nutshell of projects that we've sort of done in this sphere. I'm going to move on, unless there are any questions, to talk about some of the newer things that our group is doing, and share with you some earlier, and a lot of this is preliminary work. I don't know if anyone has any questions about some of the stuff that I've chatted about today. Okay, I'm going to move on then and talk about a study that we're doing right now, which is actually actively still recruiting patients. And so if anybody is interested in having the patients, be a part of the study, please let me know. I'll give you a little bit of the background. So this is the BRIDGES study, breast cancer's impact on diabetes and cognitive effects study. Not quite sure how those letters all got in there, but anyway, we use BRIDGES. This is a study basically sort of as the background, older breast cancer survivors more likely to have morbidities such as diabetes, right? And then we know that a large percentage of breast cancer survivors experience cancer and or treatment-related cognitive dysfunction, so chemo brain, right, during and after treatment. We also know that older adults are at higher risk for cognitive decline, right? And that chronic diseases such as diabetes can further contribute to cognitive impairment. So this is sort of like the triple threat, right? You're older, you have breast cancer, and you also have diabetes. And each of these individually, we know, can influence and worsen cognitive functioning, right? So that's sort of the basis of this study. So the cognitive function that's associated with diabetes and breast cancer generally affect these domains: memory, attention, communication, and executive function. And again, like I said, breast cancer and its treatment, diabetes, and older age, those 3 are all in and of themselves independently associated with cognitive dysfunction. So the study objective here was to examine the longitudinal relationships between cancer and diabetes illness beliefs, a lot of which I've talked to you guys already about, cognitive function, so this is the new part, and then how they may impact diabetes self-management among older cancer survivors. And the reason they've had to receive chemotherapy or hormonal therapies, these are the two that have been documented and shown in the literature that seem to worsen cancer cognitive function. So the conceptual model, sort of nice bright colors, but basically, the main issue here is the blue, which is cognition, and looking to see how cognition may then influence or impact cancer-related beliefs as well as diabetes beliefs, and then how these two interact with each other to look at diabetes and affect diabetes self-management, which then, can go on to affect diabetes outcomes. So this is very, very preliminary results because, again, like I said, this study is still ongoing. It's a 3-site study between Sinai, Northwell and Northwestern, so Northwell out on Long Island and Northwestern in Chicago. To date, we've recruited 175 women with breast cancer and diabetes. Our age cutoff, our minimum age cutoff is 55. I do not consider 55 old. Just put that out there. Approaching it very soon. But we did want to target older women, so we weren't, recruiting women in their, 30s or 40s who had breast cancer. We were really looking for 55 and older because they would have a higher risk for having cognitive dysfunction, and they all have diabetes, and they've all been diagnosed with breast cancer. We here also were using diagnosis that they were done with their breast cancer for at least a year. So we really didn't want to get into the trap that I had fallen into earlier, where they're in the middle of treatment and maybe that's really affecting things. And how I showed after over a year, a lot of the behaviors and beliefs sort of seem to equalize. So we wanted to really look at like long-term survivors, right? People who have, well, not super long, but anyway, long-term survivors, people who have definitely been out of treatment. They may be taking hormonal treatment, but they're done with chemotherapy. They were diagnosed with their breast cancer over a year ago. You can see the breakdown. The Sinai sites, have a larger proportion of minorities. So 35% Hispanic, 32% Black or African American, compared to some of the other two sites. Sinai also has a population that has lower education level and lower income than the other two sites. And again, that's partly just the patient catchment area that we serve, I think. And so preliminarily, this is like very, very early data. We looked at cognitive functioning on multiple domains. And so some of them were immediate recall and delayed recall, which is like memory, and immediate recall is more like attention. And, there are some differences by race, ethnicity, also by income level. And just so, we put in education, although we probably really didn't need to put in education because these tests of, good or normal cognition versus poor cognition meaning, cognitive impairment. I shouldn't put good and poor because I feel like that sounds judgy. I'm going to change that. Our age and education norms. So these are normative values, and looking at the percentage of people who have some cognitive impairment. What we do find is that cognition does seem to be related a little bit to self-management, so that if you have higher cognition, for whatever reason, you seem to be higher cognition on a working memory instrument, you're not eating quite as well. Similarly, higher cognition and, for executive function also seems to be associated with, not eating quite as well in terms of average days per week. Now, maybe, you could say, well, maybe the people who have poor cognition just don't really remember and they're just saying they eat well. Could be, but there is that. Interestingly, people with normal or high cognition report exercising more. And this is sort of in both the domains of working memory as well as executive function. And then interestingly, we're looking at cognition here in illness beliefs and looking at the differences between the illness beliefs. So this illness belief that their illness, that their, so DM here stands for their diabetes beliefs, and BC here stands for their breast cancer beliefs. So we're just going to look at breast cancer for right now. But, patients with lower cognition are more likely to believe that their illness, whether it's diabetes or breast cancer, is cyclical, meaning that it is not a chronic illness, that it comes and it goes, or it's, taken care of. And so this is sort of more or less across the board on multiple different domains of cognition. Similarly, the belief that treatment can help control your illness for your diabetes or for your breast cancer. So this statistical significance here is really with the diabetes beliefs. If you have poorer or lower cognition, someone cognitively impaired, you are less likely to think that your diabetes treatment can help control your illness. That's sort of some early associations between cognitive impairment and illness beliefs. And so preliminarily, we find that participants with lower cognition or cognitive impairment more likely to be Hispanic, have lower income, lower education levels, and that those with cognitive impairment, particularly in terms of attention and executive functioning, report fewer days of exercise, but more days of healthy eating. So those are their behaviors. And their illness beliefs also seem to follow a pattern where they feel that their diabetes is less controllable, and they think that diabetes and cancer is more cyclical, meaning not a chronic illness, but something that comes and goes. So again, not sure exactly what total conclusions to draw, except to sort of acknowledge and recognize that patients with cognitive impairment in this population have slightly different beliefs about their illnesses, as well as different ways of managing their illnesses compared to those with more normal or average cognition. And again, this is age normed. One of the papers that has recently come out that we did looked at cognition and motivation. So motivation here is asking about their motivation to perform a diabetes-related behavior. And extrinsic motivation means the way the questions are asked are, I exercise, or I take my medicines, or I take care of my diabetes because, my friend or my spouse or my family thinks it's important. So that's an extrinsic motivator. Like, you're doing it because people outside of yourself are encouraging you to do it because it's important to them. Whereas intrinsic motivation is, I take care of my diabetes, or I, exercise, or I eat well, whatever it is, because I think it's important, right? I do it because I want to do it, not because someone's telling me to. And what this bar graph, or these two bar graphs, are showing is that, again, the numbers go from, well, this is 0 to 6, but 1 to 6. Anyways, just the top number is 6, so it's the same for both. That the intrinsic motivation scores across, and then the bottom rows here are all these various domains that you can use to measure cognitive functioning. But across all these measures of cognitive function, the intrinsic domain scores are pretty much the same between those with cognitive impairment in the dark bar and those who are in, normal limits of cognitive functioning in the white bars. So the intrinsic motivation scores are pretty much the same for their diabetes management. Interestingly, though, the extrinsic motivations are quite different. So that the extrinsic motivation, and this is across attention and memory, these are different measures to measure different types of cognitive function, that they are rather different, and that people with cognitive impairment tend to give more weight to doing a behavior because of external forces, right? Because their friends or family recommends it, compared to people who do not have cognitive impairment. So those who do not have cognitive impairment have, relatively lower extrinsic motivation scores compared to those who have cognitive impairment. And so to summarize that, we can say that higher extrinsic self-regulation scores, so people who have higher scores on external motivation, are associated with impairments in attention, processing speed, language, and memory, but not executive functioning. And that participants with impaired working memory also have slightly, higher intrinsic self-regulation. But basically, those patients who have lower cognition, those patients who have more cognitive impairment are more likely to rely on external sources of motivation to perform diabetes behaviors. And we did control for depression. So I didn't show that in here, but we also controlled for depression because sometimes cognition and depression can be a little bit intermingled. So we did do that. But in general, people with lower cognition are more likely to rely on external sources to perform their diabetes behaviors. I have not very much time, so I'm just going to really quickly just do one last study just to tell you guys about it. This study is actually closed to enrollment now because we finished enrolling, but we're still following patients up. This is the CHAMP study, which is looking at cancer and hypertension attitudes between prostate cancer survivors and their partners. So here the cancer state is prostate, not breast, and the comorbidity state that I'm interested in is hypertension, not diabetes. And the interesting part about this, instead of looking at cognitive impairment, we are looking at caregivers and their partners, so prostate cancer survivors and partners. So it's a dyadic study. And so really quickly, 50% or up to 50% of prostate cancer survivors also have hypertension, and it's a major comorbidity. As you know, it is the primary driver for heart disease, which is the primary cause of death among prostate cancer survivors. And we know that spousal or informal caregiver involvement improves clinical outcomes in non-cancer patients with hypertension or other cardiac disease. But we don't know what they do in patients with cancer. We also know that spousal and caregiver involvement really improves treatment outcomes in patients with cancer. But again, that's for their cancer treatment, not for their hypertension treatment. And so this is where we're looking at how caregivers' beliefs about prostate cancer and hypertension is on their behaviors to support their the cancer survivor, the prostate cancer's hypertension self-management. So this is an American Cancer Society grant that is, like I said, still ongoing, but no longer recruiting. This is sort of the overall model. It gets a little bit busy, but you have the cancer survivor, you have the caregiver, you have their beliefs about their illnesses and how they relate to each other, as well as how the cancer survivor and their partner relate to one another, and that in the end, how that influences and impacts the hypertension self-management, like diabetes, and not, well, like diabetes, but including medication adherence, diet, exercise. Okay, so this is the study. We had a total of 195 patients in total enrolled. We had 47 dyads, and we had a number of patients, about 100, not quite, less, who were singleton prostate cancer patients, because we had some trouble with dyadic enrollment, so that was one reason we needed to expand it, and B, we wanted to take a look and see, well, what happens if you don't have a partner, right? Are there differences? And so we're still doing that analysis. But in any case, this is the general sort of characteristic of the patient population. Again, an older population, the mean age of the prostate cancer patients is 69. And again, it just speaks to the fact that prostate cancer tends to be the disease that happens to people as they get older. And then the caregivers, partners are a little bit younger. And then the general sort of racial ethnic spread. So this was the part that I thought was interesting, is looking at how cancer patients and their caregivers, so their partners, think about hypertension, right? And how much sort of agreement there is in terms of how much they, so the caregivers were asked, how much does hypertension affect your partner's life, right? And you can see that the kappas here, if there is agreement, they tend to be high. And the only thing that had even a moderate association with this kappa of 0.2 was this, how much does hypertension affect your life? Even though these numbers look pretty similar, again, they're median numbers, when you look at the spread and you compare the two because they're partnered, there's actually not that much overlap. And so interestingly, caregivers and their prostate cancer survivors don't actually have that much agreement in how they think about how hypertension affects one's life. For cancer, there's a little bit more agreement in terms of these particular ones. How long do you think prostate cancer will last? A little bit more similarity in terms of how the patient and the caregiver agreed on that topic or that one, and how well they felt like they understood their cancer. And so again, if you go, well, I can go back, but if you go and look at like how much does hypertension affect people's lives, survivors said 1, caregivers said 0, so not very much. Whereas if you looked at these numbers, how much does prostate cancer affect your life? 5 and a 6. So I didn't sort of point that out, but again, cancer survivors and caregivers both report greater concern about and emotional impact of prostate cancer compared to hypertension, and less controllability of prostate cancer compared to hypertension. So there is some agreement, but in general, the agreements between the dyads were not very similar. So overall, these are the concepts, but in between the dyads, there's not that much similar. There is greater congruency for prostate cancer beliefs regarding prostate cancer chronicity and how well they understand. And I realize we are at time, and I don't think I'm going to really go into comorbidities and cancer that much, although I just want to, make sure I end on time. The comorbidities and cancer is really to do with some work, and this is relatively earlier work that I did that looked at how diabetes medications in particular may affect cancer outcomes. The gist of it is that, if you look at metformin seems to be somewhat protective, at least in late stage lung cancer. So with that, I'm going to stop talking just ask if anyone has any questions. I can stop sharing, or I can just
yeah. Thanks, Jenny. This is fascinating, and clearly lots more to talk about. So thank you for doing this. We've got time for 1 or 2 quick questions. Maybe if people want to unmute or put a question in the chat. Maybe I'll just ask you if, as a primary care doc, how do we counsel patients based on all this stuff that we know or are starting to know?
Yeah.
How does that change what you're telling patients either about cancer or about diabetes?
So I think, I do have some cancer survivors in my practice, and there is an oncogeneralist practice that is here in the Uptown group. I think the main thing is just to remember that cancer survivors, generally, depending on what cancer they have, but generally they're going to end up, having complications from their primary illness or their pre-existing comorbidity, and less so the cancer. That's not to say to totally disregard cancer outcomes, but I think it's really important to remind people that even though they may have cancer, they still really need to think about and continue to manage the other pre-existing illnesses. So I think that's the first message I would sort of say as a primary care physician, the clinical take home. But then the second thing is just to recognize that many people have multiple comorbidities that they are working with, and that specifically in cancer survivors, people have very different beliefs about their different illnesses and how those beliefs may then interact or impact one another in terms of taking care of not just the illness itself that you have the belief about, but another illness, and sort of being able to sort of think about and talk to patients, even if you're taking care. So, for anybody in this group who's like a cardiologist or, a pulmonary doctor, that, even though you're taking care of this one illness, that just remembering that other illnesses and other things that they have in their life may be impacting how they're taking care of the illness that you're focused on, I think is an important thing to remember.
Great, thanks. Team 12, you're unmuted. Was there a question from over there? Nothing. Okay. All right, we're right about at 1 o'clock, so I think we should call it a day. Thank you so much, Jenny. Always good to see you.
Absolutely great to see you guys. Take care.